All right, good afternoon. This is Dr. Johnson. I'm here for a webinar to start on my aching back. I'm going to start in just a minute. I'm going to let you know that you're welcome to ask any questions throughout the presentation, and we'll try to get to all the questions by the end of the presentation. It'll take about 20-30 minutes, and then we'll have about 30 or 40 minutes of questions. I'm a neurosurgeon here at Hermann Memorial Hospital at the University of Texas. We're going to start with low back pain. Low back pain is actually very common amongst Americans. Sometime during your lifetime, you'll have approximately a 60 to 70% chance of developing back pain. It's the second most frequent cause of visit to a physician. It's also a very common cause for hospital admission as well as surgery. It's also one of the largest causes of why people lose days at work. Before we start, I want to go over some of the basic anatomy. Here we have a herniated disc, which is usually round like this. It actually sits over here over the vertebral body, which is a big block of bone. In the back of the vertebral body, there's a hole right here, which is where your spinal nerves run through. They're contained in the sac called the dura. Here, the vertebral bodies are all stacked up with the disc in between. The joints, which are known as facet joints, are here in the back of the bones. They're also shown here on a different view. Now, there are many pain generators in the lumbar spine. The most common is a paraspinous muscle injury, and that's kind of where people complain of throwing their back out, their muscles are hurting either on the right or the left, especially with movement. We also have the vertebral body, which is the big bone and building blocks of the spine, which can have fractures or microfractures, which can cause pain. The facet joints, which are the joints in the back of the spine, can also move against one another, leading to pain. In addition, the disc can cause pain either through herniation or just degenerative disc or loss of water in the disc. Common causes of back pain include compression fractures, herniated disc, degenerative disc, and spinal stenosis, which is a medical fancy word for the space where the spinal nerves are, is just much smaller than normal, which leads to nerve root compression. The first thing we always try when patients either go to their primary care doctor or to our office is non-operative treatment. There's a whole host of things that we can do. It includes NSAIDs, which are things like ibuprofen or anti-inflammatories, muscle relaxants, pain meds, oral steroids. If the medications fail, we can also send you to a pain management specialist who can do injections such as epidural steroids, trigger point injections, facet injections, maybe some rest as well. The other things we recommend are perhaps changing your activities or things that you do temporarily while you get through that process. Definitely physical therapy is something we recommend for all of our patients. Have a short course of physical therapy before they even contemplate surgery. In addition, we do things like heat, massage, ultrasound, a TENS unit, which is something that can kind of vibrates the muscles and can alleviate the muscle pain that some patients have. In addition, traction, braces, acupuncture, and behavioral therapy as well. When you go to your primary care doctor or your surgeon, there are certain tests that they'll do to assess why you have low back pain. First, you usually do x-rays. Second is flexion extension x-rays, which are you moving your back backward and forward to see if there's any abnormal movement in your spine. Next is an MRI, which actually shows us the disc and also the nerves very well. CT myelogram or CT scan, which actually shows the bones very well. A myelogram is something we do if you had previous surgery, so we can try to distinguish things such as scar tissue and herniated disc and the position of the nerve roots. A discogram and facet blocks and nerve root blocks, which you get from the pain management specialist, can also help us to identify exactly which nerve or which joint is causing your pain. Here we have a radiograph of compression fractures. Here is a normal building block, so a normal vertebral body, which is one big square. If you look up here, this actually has a dip here at the top at the L1 vertebral body, of which this has been compressed from the top down. This is actually a very common fracture in either minor injuries or car accidents that present either to the emergency room or to just a physician's office. Here's a radiograph. Right here is a compression fracture of L1. You can barely even make out that this is actually a whole building block vertebral body. This is more common in patients who are osteoporotic, which is very common in women over the age of 55. The treatment that we use for a compression fracture is actually a minimally invasive procedure called kyphoplasty. What we do is we insert a needle into the bone here. We then blow up a balloon into the vertebral body, which then restores the height of this bone compared to the compressed version over here. Next, this balloon leaves a hole here that we deflate the balloon, take it out, and actually fill it in with cement, which maintains the height of this vertebral body. Here's before and after. Here's a compression fracture right here. You can see that curvature. This again is a normal vertebral body here. Go over to the right and then you'll see this is actually the vertebral body after we've expanded it and placed cement into it. And it's actually almost as big and quite normal compared to the rest of them as well. That's a procedure that we actually do either in the surgical suite. Most patients go home that day or the next day at the latest. As soon as they go home, within a day or two, it actually alleviates the horrible back pain that they had related to this compression fracture here. So within a day via this minimally invasive procedure, they are leaving the hospital, their pain is gone, and they're usually back to work in a day or two. Other options for a compression fracture other than the minimally invasive kyphoplasty includes surgery. Here again, you can see the compression fracture. You can go in and put screws above and below the fracture, kind of stretch it back out into place. This can actually also be done minimally invasive through a tube as well. The recovery from this surgery is usually a couple of days, and people are usually back to work within a week or two. This patient, unfortunately, is not as lucky as the others. This bone is actually turned backwards towards the spinal canal, is actually compressing some of the nerves here. For that reason, we actually need to remove this entire bone. That requires a much larger procedure where you remove the bone and put in a cage that looks like this here, and it requires some screws above and below in order to stabilize the spine. This is a procedure that the patient will probably be in the hospital for about 3 to 5 days. Will probably recover at home for 1 to 2 weeks and is usually back at work somewhere between 2 to 6 weeks. Very common that we see is also a herniated lumbar disc. Here we have, this is our sac here of nerves. Each nerve then exits in between the bones right here. Unfortunately, if you have a herniated disc, which is this bulge right here, it then pushes on the nerve, causing usually leg pain, also sometimes some back pain. You can see there's a weakness that was right here in the covering of the disc, which allowed the disc to then herniate. This can happen either because as you get older, this actually is weaker, or it can happen from a traumatic event or some kind of a sports-related injury as well. The way that we address this is a minimally invasive lumbar microdiscectomy. We make a very small hole right here through the skin. This is a tubular retractor that we put all the way down to the area where the disc is. Again, these are the vertebral bodies here, the disc is here, and the nerve root being squished by the disc is right there. Again, here's the retractor system as it sits right on the bone. We can actually, it's a small incision through the skin. We try to not disrupt any of the surrounding muscle in this area. We drill off a little bit of bone right there. And when we do drill off this small piece of bone, we are then looking at the herniated disc down here. We can push the nerve root aside and just shave off the herniated part of the disc. This little tube then comes out. We close this 1 centimeter incision here, which is about the size of a nickel or dime. And the patients usually go home the same day or the day after, and they're usually back to their normal activities within 2 weeks, and most patients go back to work 2 or 3 days after having this procedure done. This is actually what it looks like for us in surgery, is we put the tube in and we actually localize the area where we're at. Here are the vertebral bodies, and here's the herniated disc here that we're going to address. Degenerative disc. This actually occurs when there's a loss of blood flow to the disc, there's loss of water content in the disc, which unfortunately happens as everybody gets older, and the disc space collapses, which leads to bone-on-bone contact, which is what this picture here shows. Here's the bone, a nice healthy disc in the middle, another bone right here. When the disc degenerates, which happens as you get older or maybe with additional use if you played a lot of contact sports or were very active when you were younger, the disc right here has now disappeared. It's lost all of its water. It's gone down in size. It's squirted either out the back or the front. There's bone contacting bone, and the micro movement of bone against one another actually is a huge pain generator for back pain. In addition, this puts stress back here on the joints and the facet joints as well. Here we have a radiograph that shows the same thing. You can see here there's normal disc height right here. There's an area here, which is where the nerve root exits, which is quite large. As you look down here, this disc space is markedly smaller, and the area here where the nerve root exits is also smaller. This is the MRI for this radiograph as well. And this shows right here that this disc is actually not as bright as the disc up here. It's lost its water content, it's shorter, it's squirting out towards the front as well as the back. Here's where your nerves normally are. We have many different ways to try to address discogenic back pain, which we'll discuss. The objectives of treatment for a degenerative disc disease are to decrease pain, improve your quality of life, decrease disability, increase your ability to work, and to try to alter the natural course of the disease as well. There are two surgical options, which is an anterior lumbar interbody fusion, otherwise known as an ALIF, or a posterior approach known as a PLIF. The reasons why we do these surgeries is to decompress the nerves, to remove the degenerative disc, to fuse the disc space, and to immobilize the joints. I'm going to show you the ALIF procedure first. Again, this is someone here who has normal discs right here. So the area that we're concerned about that's causing their pain is actually right here where it is collapsed. This is the MRI for that radiograph, which again shows a disc here which is collapsed and lost its water content compared to the disc above here. And this is the generator for their back pain. Right here you'll see these are the interbody cages that we'll be placing into this patient that I just showed you right here. What we do is you actually come in from the front around the belly button. It makes a small 2-centimeter incision. We do this in conjunction with a general surgeon who moves everything aside, gains access to the front of the disc space here. We then clean out the disc and we put one of those spacers right there. Procedure takes about an hour to an hour and a half. And as you can see here, this is the disc space with the spacer in there, and now the space of this disc here is the same as it is above. We've restored the height, and the hole here where the nerve root exits is now the same as it is up here. This patient then gets relief of their back pain, usually is in the hospital probably about 3 to 4 days to recover from surgery, and is doing very well at home for about 2 weeks and returns to work somewhere between 2 to 6 weeks after surgery. This is a CT scan, which actually shows here's the interbody cages, one on each side, that's placed into the inner disc space right here. The results of this surgery are actually much better than they used to be. Fusion rates are as high as 96%, and people actually get reduction in their pain and improvement at least 90% of the time. Also, this procedure is advantageous as we avoid all muscle trauma, mostly because we're going from the front part where there are abdominal contents. There's also less blood loss, and also less likely production of scar tissue as well. Now we can talk about the posterior lumbar interbody fusion, which is a surgery we do from the back of the spine. See, here's the back of the spine right here. We would come in from this area. This can be done either openly or minimally invasive. This is something you'd have to discuss with your surgeon as to which approach this would be done. Again, right here are the facet joints on each side. A screw is placed on either side of the spine, right into the vertebral body. You'll see here that between the vertebral bodies, once you remove the disc, we then place bone graft right here. We place a cage here as well from the back side and more bone graft. Your body over the next 3 to 6 months will then fuse this into one solid fusion mass. Up here is a normal happy disc, which is nothing that we would need to do anything with. This is what it looks like on an x-ray after surgery. Again, you have the screws here. There's 2 here, and there's 2 here, 1 on each side. And in the middle here is a large piece of bone graft. The body will then fuse from this vertebral body down to this vertebral body. Now again, this whole procedure could be done minimally invasive or open. It depends on your body habitus as well as the surgeon. The results of this surgery is actually very good. Fusion rates go from approximately 80 to 100%. Most of these are greater than 90%. In addition, patients have excellent functional outcomes as high as 85%, which means they have a decrease in their back pain as well as in their leg pain. The advantages of this procedure is that it can actually treat both the pain related to the disc and the joints. It allows for decompression of the nerves. Spinal stenosis is another common problem of back pain. And again, unfortunately, this happens as you get older. And there's not much we can do about that, but we can try to fix it. Spinal stenosis is a fancy word for meaning that this hole here, where the nerve roots are and where they exit, is smaller than normal. Some folks are born with shorter pedicles, which is this bone here. And if this bone is smaller, that means that this comes down and this area is smaller. And those patients are more prone to developing spinal stenosis and back problems. And this is something that if your family has had a large history of back problems, that more than likely you may as well. Here you can see what has happened. This is a good example of spinal stenosis. Here's the joint, the facet joint here, which is actually enlarged. And that's a form of arthritis that happens as you age as well. As this enlarges, it encroaches on the middle here where the nerves are. In addition, this roof can also enlarge and the bone can thicken here and decrease that area as well. There's a ligament that runs right here which can hypertrophy, which is a fancy word for enlarge as well. And if this enlarges, it also decreases the amount of space available. In addition, on the front part of the spine is where your disc is. So as your disc herniates backward, it can also herniate out this way and decrease the space. And this leads to spinal stenosis, which can be caused from a multitude of areas in the spine. There's a few surgeries that we do to address this. The easiest one here is called a laminectomy. And this can also be done minimally invasive. We go in here and just basically drill out bone to create space. Once we drill out the bone here, now the sac of nerves has lots of room. In addition, the exiting nerve roots here have additional space. If there's a herniated disc as well in this area, we can pull the sac over to the side and shave off the herniated part of the disc. If there's also a combination, in addition to the spinal stenosis and degenerative disc disease, then in addition to this, we would actually also do a fusion that we saw previously. We would put screws in on both sides and actually perhaps move this aside, take out this disc and put a spacer in there for fusion, which would address the back pain as well as the leg pain. People who have spinal stenosis also have neurogenic claudication, which means that you're unable to walk further and further. Let's say 3 months ago, you were able to walk for 30 minutes before you had to rest. Now you can walk maybe 3 or 4 minutes. You have to sit down. Your legs get heavier. You also have back pain associated with this. That's signs of spinal stenosis, which means that you probably have this here going on. Success of surgery for this procedure is actually very good. Patients walk out of the hospital usually within 3 to 4 days. Again, they have about a 1 to 2 week recovery at home, and they're back at work within 2 to 6 weeks. Here's a cartoon of what's going on. You can see here, this bone is a little bigger this way. It's a little bigger this way as well, which then narrows the space where the nerve roots are. Once we come in from behind and drill off that bone, which is a laminotomy or laminectomy, you can see that it then restores space for the nerve roots to flow into, which now we've actually decreased the possibility of having those nerve roots squished, and now that they're free to move about. Results of that surgery are very good. There's a 70% long-term success rate. And it does affect leg pain more than back pain. It's a surgery that is more successful to get rid of leg pain than it is back pain. If you have back pain, the surgery that you would need would probably be a fusion surgery, as that's the kind of surgery that has the best result for eliminating back pain. The last slide here is actually our contact information. If you have any additional questions or want to get a hold of us after this webinar, I thank you for listening to the presentation. I think now we are going to open things up for questions and go over some of the questions that we have. All right, our first question I'm going to read. It's a patient who has a diagnosis of a herniated or bulging disc at L3-4, which is causing sciatica, so I'm assuming it's leg pain. They've tried oral steroids, physical therapy, steroid injections, but the pain is back. Unfortunately, it sounds like you've tried all the conservative management so far. Unfortunately, the patient seems a little hesitant to go to surgery, which I understand. We have a lot of folks that have done that. I think you've run into some very good people who have pushed you into the area of conservative management. I think you've tried all of the conservative management, and so far that's failed, which is the time to consider surgery. And the rest of the question reads, is minimally invasive arthroscopic an option I should consider? If so, what do the statistics say for efficiency of this procedure for my type of problem? If you have a herniated disc that's causing right or left leg pain, I think you're a candidate for the microdiscectomy procedure that we talked about, which is the minimally invasive procedure. It has an incision on the skin that's about the size of a dime or a nickel. We can easily go down right to where the herniated disc is, shave off a little bit of the bone to get to the disc. And then after that, we can actually just go and shave off that herniated disc. Once you take off that herniated disc, that should get rid of your sciatic problem. Patients do very well from the surgery. You can go home that day or the next day and probably be at work a couple days later, or definitely within 1 to 2 weeks. All right, our next question is, if a patient requires surgery and has bilateral upper extremity lymphedema, how would vitals be monitored since the arms cannot have injections, IVs, or blood pressure cuffs? It's a very good question. Luckily, we actually have different ways to monitor all of that. The blood pressure can be taken and the IVs can be taken actually into the legs or into the groin area, where you have very large vessels there that we can actually monitor either via an arterial line, which is a little catheter that we put into the artery there to measure blood pressure, or the blood pressure cuff can be placed on the leg or thigh. In addition, the IVs can also go into the leg, the thighs as well, and into the feet. So even though you can't have anything put into the arms, we're definitely able to do surgery if that's something that you need. All right, our next question asks, how much loss of mobility is there with fusion? In back pain, if you require fusion surgery, it does depend on the number of levels of fusion. Most of the bending that you do is actually at your hips and not so much in your back. So when you bend over to try to touch your toes, that initial bend where you're about a foot, maybe a foot and a half away from your feet, is mostly from your hips. The extra foot and a half to get down to your toes is your mobility actually from your back. So having a one-level fusion in your lower back does not limit your mobility by much. That's very noticeable, unless you happen to, you're limited by your pain. So once you've recovered from surgery, your muscles are back to their normal strength, there isn't too much that most patients realize. Once you start increasing the number of levels of fusion from 1 to 2 or 3, or some patients have even 5 or more, you are going to lose, with each incremental level, a certain percentage of your mobility. And I'd say about 5 to 10% per level for your lumbar spine. All right, next question talks about flexus, which is or X-stop for lumbar spinal stenosis. I personally actually don't have much experience with flexus, but I do, and I have put in the X-stops. An X-stop is a device that's cylindrical that you can actually put in a minimally invasive way when the patient's awake, but sleepy and under some anesthesia, through a small, maybe 1 to 2 centimeter incision on the back. Just put that between the spinous processes, which puts the patient in some slight extension, meaning that you're leaning slightly forward. When you lean forward, it actually opens up the space where your nerves are, and it creates more room, which makes the spinal stenosis a little less and makes the space where your nerves are exiting much larger. So if you gain some kind of relief when you lean forward, this is a procedure that we consider for you. The good thing about this procedure is that it can help you. It can eliminate the problems that you're having from your spinal stenosis. And in addition, it's a very easy surgery to get away with. It's something that you go home the same day. You really haven't burned any bridges. If you need additional surgery later on, it does not create much scar tissue at all. It does not disrupt the ligaments much or the muscles very much either. Next question is, are there any activities that I won't be able to do after fusion surgery in the short or long term? There are things that you definitely cannot do in the short term after fusion surgery. For my patients, I actually ask them to take it easy for about 6 weeks. I have them do as much walking as they can do. They can walk up to 10 to 15 miles a day as long they're just limited by their own pain. The one thing I ask them not to do are things that I would call bouncy activities, which are basically anything where your spine compresses on itself. That includes riding an ATV, jumping on a trampoline, motorcycles, horseback riding, jumping out of planes. Anything where your spine would be compressed repeatedly is probably not a good idea until about 3 to 6 months after surgery. So in the long term, after your spine is completely fused, there's actually no limit to the activities that you do. You do want to protect your spine. You don't want to lift heavy objects more than 40 or 50 pounds. You want to try not to help your friends move their heavy furniture if that's what they're doing. In addition, when you do have a fusion surgery, you do change the physics and the dynamics of the spine slightly. What this means is that the area above and below your fusion, you put that disc at a higher risk for herniation or degenerating later on in life. It's about a 10 to 15% rate of possibly needing additional surgery over your lifetime when you have a fusion surgery, either above or below that fusion. So you do want to try to protect your back, do activities that are within reason, but the restriction is usually let up within 3 to 6 months. All right, our next question reads, I have a degenerative disc at L3-4 and L4-5. I also feel a bump on the left side of my spine at the belt line. I feel bone-to-bone contact and pain. The surgeon wants to shave off the protruding disc part. Does this sound like what I might need? I'm not sure. By what you're telling me, you do have degenerative disc. You must also have a herniated disc as well if they're wanting to shave off that part of the disc. If you're having only leg pain, then going and taking out the herniated part of the disc, pushing on the nerve can alleviate that leg pain. If you're having a large component of back pain in addition to your leg pain, then the only real way to address your back pain is a fusion surgery, unfortunately. And that would require, again, the interbody fusion between the vertebral bodies and the instrumentation in the back. The good thing is that surgery can be done minimally invasive, which is an easier surgery to do, easier surgery for you to recover from as well. But it sounds to me like you also, if you have bone-on-bone contact, that means the disc is completely gone. You may want to restore that disc height, which would require fusion surgery and an interbody placed between the discs there, or between the vertebral bodies where the disc once was. Next question. Are there alternatives other than surgery you recommend trying first? I recommend that all patients try conservative management before considering surgery. So the things that I would recommend are physical therapy, which is usually if you go to a sports medicine or a physical therapist who deal with patients with back pain and leg pain, they have already made programs that you can go to that help to strengthen your core muscles and stretch out your leg muscles, and actually have a very good success rate of either decreasing or limiting your back pain and leg pain such that you don't require surgery. If that doesn't work, then I recommend pain management as well. Pain management can actually go in and do epidural steroid injections or injections into the joint if that's what's causing your pain, or injections right into the nerve root, perhaps that's also leading to your pain. So those areas are something that I would pursue. Other things that people do, some of them go to see massage therapy, do as much walking as they can. I would also try some medications as well. If you're having an acute reaction and an acute leg pain, you can also do a short course of oral steroids, which can help decrease the inflammation around the irritated nerve root, which may give you some relief and get you over the area of your pain. All right, next question. We have a patient with an S1, S2 disc. Sounds like it's degenerating. He's tried oral steroids, therapy, Pilates, but not steroid injections yet. He has mostly back pain and is a runner, but he unfortunately had to stop running 2 years ago due to the pain was getting worse. It sounds to me like the one thing you haven't tried are the epidural steroid injections. This is an area that the pain management specialist can easily get to, especially if your pain is mostly back pain. Again, back pain, a fusion surgery at S1, S2 gives you probably a 50 to 70% chance of back pain improvement with a fusion surgery at that level. I would recommend seeing a pain specialist and having the epidural steroid injections to see if that gives you some relief. When patients get the injections, sometimes they last for a couple weeks or a couple months or a couple of years. Every patient's a little different, but if they work for you, I think getting the injection once a year or once every 6 months for a while is much better than having surgery. If you can avoid surgery, it's usually a good thing. Sometimes you can just delay it. You know, everyone's a little different, but it's good to try all your options before considering surgery. All right, next question. Someone has a arthritic fusion of L5-S1. Looks like a fusion of S1, some scoliosis, a hemivertebra at L3. The question is, does use of cortisone cause additional degeneration due to the cortisone? Blocking the pain may be masking a critical message. So the steroids that you use do not cause additional degeneration of the disc, but overusage of steroids, especially oral steroids, can actually cause osteoporosis, which can lead to other problems as your bones get weaker. So if you're taking something like a lot of cortisone or corticosteroids or oral steroids, this is something that you should probably also take some kind of supplementation to build your bones. These are cortisone shots that you're taking directly into that area. Again, it's something we try to limit to only 3 times a year because it can have similar effects. But it's something that usually does not cause your degenerative disc to worsen. The steroids are actually, sometimes they could be masking something that's going on, but most often a steroid is an anti-inflammatory. So if your nerve roots are irritated and then they swell up and they're inflamed, if you give an anti-inflammatory, the swelling goes down, which then means that there's more space around that particular nerve root than there was before when it was swollen. So you didn't actually change any of the mechanics of the spine, but you were able to decrease the swelling, which in a sense created more room. So although sometimes you can mask the pain of what's going on, you can actually treat with the steroids as well. Next question. I have a spinal decompression with a computerized machine for 2 months. I have been diagnosed with a degenerative disc disease, spinal stenosis, herniated disc, severe chronic debilitating pain. I am not pain-free, as I saw in many video testimonials from other patients, but have improvement with core strengthening exercises. This procedure have lasting results. The lasting results usually are not permanent. What the spinal decompression does is it actually kind of pulls the spine a little bit, and when you pull the spine and stretch the spine a little bit, it creates more room again for the nerves as well as the exiting nerves. A lot of patients can get relief of their degenerative disc as well as their herniated disc, so they're pushing on nerve roots from this. This is usually, unfortunately, not always 100%. And it's not permanent either. But the good thing about this procedure is that it does give you some temporary relief so that you can perhaps participate in things like physical therapy or Pilates to increase your core strength and to get more active, which may also have long-lasting effects on the issues and problems that you're discussing. Next question is, does inversion therapy have any chance of helping a herniated disc? Inversion therapy is kind of along the same lines of the decompression therapy we just talked about. There's no harm done by inversion therapy. Again, the idea is that they kind of turn you upside down and use your own weight to kind of pull your spine to perhaps increase the space that your nerves are in to relieve the pressure on your nerves. So if you have a herniated disc pressing on your nerve, if you're able to stretch out your spine using inversion therapy, again, when you create more room, it can help out with the leg pain that you're having, but it does not take care of the problem. If it helps you, though, and this is something you can do every time you have the leg pain, then that's great. If it doesn't provide any relief, then it's something that would probably stop. Patients have varying results with this, but again, there's no harm done in trying. All right, I have a couple questions here on laser back surgery. So around the country, there are some laser back surgery clinics that do minimally invasive procedures. I've read some on what they do. This is not something that I do or that anyone I believe in Houston does. But they can go in and basically they put a little catheter into the disc or around the nerve root and kind of heat that up to cause some scarring and burning in that area. Some patients state that it does help out or it does eliminate perhaps their back pain or their leg pain. Other patients say that they have no success with that at all. It's very patient dependent. There's a lot of studies that these laser back surgery institutions give out. Again, there's risk to this procedure as well, such as injury to the nerve root, just as there is risk with surgery as well. Again, my opinion is that there's no harm in talking to them and finding out information. It's not something I recommend for my patients, but it's something that is an option that you can easily pursue. And here's another question about the laser surgeries, that there's a few spine groups around the country that specialize in these procedures. Again, I don't believe there are any of these in Houston. The ones I know about that might be close are usually in Florida and California that I've heard about. And again, you know, it's something that you can try. I'm not a big fan of this only because I haven't seen it work in many of the patients who come back to me. But again, I have a biased population because they really only come back and see me if it doesn't work. So I don't see the patients that may have some good benefit or positive benefits from that particular technique. All right, I think I've answered all the questions that are currently in the chat room here. We still have a little bit more time left. If you guys have any additional questions that you'd like to ask or put through, or if you already asked your questions and I didn't answer exactly what you wanted, feel free to rephrase them and put them back. All right, our next question. I have a C5-6 or C6-7, I assume herniated disc with pain that radiates down next to the right scapula, which causes knots, and pain that travels down the right arm to the elbow. I think that sounds like you have one or two herniated discs. The pain that you're describing goes along with those herniated discs in the same nerve root distribution. Again, I don't know how long you've had this or if you've tried conservative therapy. First, I would actually try conservative management, which includes physical therapy, and see how that works for about 4 to 6 weeks. And if you're not getting any better, you can try a pain management specialist who can actually, who we refer you to, and do an injection right into the nerve root to see if that eliminates the pain that you're having. Again, if that does not work, then your options are surgery at that time. And the type of surgery that you would need would be in your cervical spine. It's called an ACDF. Anterior cervical discectomy infusion. It's a surgery that's done from the front of the neck. We go in from the front and we move the trachea and esophagus off to the side. We remove the herniated disc from over the spinal cord as well as from the exiting nerve roots. The next thing that we do is we put in a little spacer, just like you saw on the slideshow for the lumbar spine, and then we put a plate and some screws over the top. The plate is very low profile, it's just a couple millimeters thick, and the screws basically hold everything in place while your body does the fusion work. Over the next 3 to 6 months, your body will then fuse from one vertebral body to the next over the disc space. Patients recover very well from this surgery. If you have a 1-level fusion, you go home in 1 day. If you have a 2-level fusion, you usually go home in 2 days. Most patients are back to work if they have a nice, easy desk job about 2 weeks after that. If not, everyone's back to work within 6 weeks. Next question is, what steps do we need to do to get evaluated? What to do is, if you have a primary care doctor, it's probably the best place for you to start, especially for your insurance company, to let them know that you have low back pain. They'll usually order some x-rays or an MRI, depending on what your complaints are. When you get the results from them, if it appears that there's something that needs to be addressed, then you can go ahead and go see a neurosurgeon or an orthopedic surgeon to address your spine issues. And you want someone who's spine trained, who's done a spine fellowship, who kind of knows what they're doing with the spine. And again, we have the number here up on the screen. You're welcome to give us a call. If you don't have a primary care physician or you don't care for them very much, you could actually call us directly and skip that step. It's up to you. All right, next question is, what is the cost range of doing minimally invasive discectomy for herniated disc? I can tell you, I honestly don't know. So that's not so. I don't really keep track of the cost per se. I know that for us, it doesn't really matter whether it's a microdiscectomy or an open discectomy. We get reimbursed the same. But the procedure, though, is actually very small. I couldn't imagine it costing more than a couple $1,000s. You just have to probably pay the copay from your insurance. And but that's something that we have a financial department that sits with the patients, actually tells them how much the surgery will cost, tell them what their part is, whether they do or don't have insurance, and what they estimate the cost to be before they ever agree to have surgery, so that the patients are fully informed. Next question is, after the minimally invasive surgeries, does normal activities include lifting, especially a child that I'm caring for who weighs approximately 20 pounds and is not walking alone yet, to take care of the child from Monday through Friday? So that's a good question. If you have a minimally invasive procedure, we ask you for about a week or two not to lift anything heavy. Between 2 to 6 weeks, if you have a child who weighs 20 pounds, you can probably lift 20, 30 pounds between the 2 to 6 weeks without any difficulties. You're basically limited by your own pain. The muscles may be a little sore the more weight you lift. After 6 weeks, we start to even lift those restrictions, and you can start to lift things such as 40 or 50 pounds after that. So unfortunately, you would have a few days to maybe a week or two of trying to lift as little as possible. But shortly thereafter, you would be able to go ahead and lift the child, as well as anything between 20 and 30 pounds, and by 6 weeks, almost anything you really need to lift. Next question is from our individual who had the S12 disc. I had suggested some steroid injections from pain management, which could help sometimes for a month or a couple of years. His doctor suggested that if he has the surgery now, they can do it from the front, and if the disc fused because it is very thin, the surgery has to be done from the back, and he's asking for any suggestions. That is partially true. If there is, if the bone is on bone and there's no disc in between that, the body will actually start to fuse on its own. If that occurs, then doing a surgery from the front in order to try to increase that disc height, to put a device in there to put the disc height back to normal, would be more difficult. I don't know how small your herniated disc is, but it does take a while for the disc to completely disappear and for the bones to come together and fuse. You can actually see implate changes, which are called modic implate changes, on an MRI before the disc will disappear. And if you're having those particular changes, then that does mean that you're on your way to doing that, and that actually would be true, that there is a possibility if the disc disappears that you would not be able to have an anterior surgery. The other thing about an anterior surgery at S12 is this is not something we recommend for men who are of childbearing years. There is a certain percentage of patients and a risk where you can get retrograde ejaculation, which would make you sterile, unable to have children, and can cause actual sexual dysfunctions and problems. So this is also a risk that needs to be discussed with your surgeon, depending on what category you're in and what your family plans are. We have another question from a gentleman who had the L3-4 and L4-5 disc that we talked about. This apparently happened at work about 9 months ago. He's a truck mechanic. The workman's comp insurance doctor says that his problems are caused from stenosis and age, and have denied the surgeon's request to do for a laminectomy. Yes and no. So we work with the workman's comp insurance companies quite a bit, and sometimes they are difficult to deal with. Now, having a degenerative disc or getting older does put you at a higher risk, but having an actual injury at work means that you're at a higher risk for developing a herniated disc or developing problems of nerve root compression, but at one particular event can actually then herniate the disc. So it does predispose you per se for having problems, but that usually doesn't create that event that causes a problem. Usually, if you go through enough appeals and talk with the workman's comp and explain that to them, and the event that occurred, that it could possibly have occurred because of this event, it does get through. Sometimes it takes a few months, maybe up to 6 months, but you do have to explain it that even your degenerative disc puts you at a risk. It wasn't what actually caused your problem. All right, our next question asked that during physical therapy, would anabolic steroids assist in healing and strengthening? That's an answer I don't know. I would say that anabolic steroids do help some individuals while going through physical therapy to develop more muscle mass and more muscle strength. To my knowledge, it is not going to induce injury or to your body, and that's kind of a personal choice as to if that's something that you would really like to do. The physical therapy I highly recommend. The anabolic steroids, to my knowledge, would do no harm to you, but that there are some other side effects related to those that you would have to discuss with your doctor to see if you're okay with them, so that you're fully informed as to the side effects of those steroids. All right, I think that was the, I thought that was the last question, but we have someone else in here. Question says, an orthopedist told me that studies show that after 1 year of people who have herniated disc surgery and those who have no surgery do not have significant differences in status. Is this true? Not exactly. So there is a study that came out, and I think it was probably a good 10, 15 years ago, that showed that it was actually 5 years after someone who had a herniated disc, the disc was less than, I think it was 6 millimeters, that people who did conservative management, such as physical therapy and epidural steroid injections, versus people who had a microdiscectomy, 5 years later, they had equivalence in the level of their back pain or leg pain. So that part of the story is actually true. The issue with this is that some patients don't have 5 years to try to suffer through their back pain and their leg pain. They may need to return to work because this particular pain may limit their ability to work or to interact with their families or their children. So sometimes it actually depends on the patient as well. If you need an immediate relief of your pain and your symptoms, then surgery is probably a better option for you if the conservative management has failed. But if you're someone who is able to go through the conservative management, knowing that it may take up to 5 years, then that's a route that you can go down as well. And patients who do the conservative management, which is why I highly recommend this to all of our patients to at least try, can be very successful at eliminating their symptoms and basically avoiding surgery. Next question is there permanent damage to nerves if I continue conservative therapy? Should I have an evaluation no matter what to determine what level of problems I actually have? Yes, I think you should have an evaluation. Most of the things we're talking about are pain related. If you have symptoms of a herniated disc or anything else, or spinal stenosis, that include things like a numbness, a tingling, and especially weakness in your legs or with the particular nerves in your legs, that's something that's very worrisome. You may not, even though you may undergo conservative therapy for a couple of weeks, but if things haven't improved and gone away after that, then it's something that you would want to move to surgery much quicker. You don't want to lose function in one of your nerve groups. You don't want to get a foot drop. You don't want to not be able to walk or all of a sudden lose feeling in your legs, because if that occurs, then it's hard for you to walk and get around, and your quality of life is not very good. So those kinds of weakness and paresthesias and numbness we consider in a different category than just pain alone. Patients who have just back pain or leg pain, things like conservative therapy, you can keep going on that for quite some time. If your exam changes And not only in addition to the pain, you now have something like the weakness or the numbness, then you definitely need to get reevaluated by your primary care doctor or surgeon to decide whether or not you need to change your course of therapy at that time. All right, looks like that was our last question, and that we have actually used up all of our time today. Thank all of you guys and girls for listening in on the session here, and for hopefully it was informative. You learned something about the back. Again, if you have any questions later on, there's a number and a website up here on the screen. You're welcome to come and give us a call or let us know. And I look forward to talking to you soon. Thanks.